Ja, god dag dit, og velkommen til hese verjen I dag. Jeg heter Hans Paul Johansen, og dekan for Norðurlondum av Føroyskir. Og jeg skal leie seg her verjene som vi I dag. Men vi får at her et her enskånd, så vi får at skifte over til engst. So we're welcome to all of you. Where Marnar Fríðheim Kristiansen is going to defend his Ph.D. Thesis, Cancer Epidemiology in the Faroe Islands. The supervisors for Marnar have been Maren Strøm and Maria Skålum Petersen, both from the University of the Faroe Islands, and Bjarni Stæ, consultant at Landsjúkrahúsið, the Faroese National Hospital. We are very pleased to have all the examiners here in person. We have had some defenses where we have used the internet because of the corona, but it's hopefully almost over now. But we are going ahead here, so very welcome to all of you. The chair of the examiners is Paul Verja. He is a professor at the University of the Faroe Islands, and he is also a consultant and head of Deildin fyrir arbeids- og almannaheilsu. And then we have Professor Henrik Møller, who is a lead epidemiologist at the Registry in Denmark, and he is also a professor of cancer epidemiology at Aalborg University, and he is emeritus professor in cancer epidemiology at King's College, London. And we have Dr. Elisabeth van Eucken. Yeah. She is director of the Belgian Cancer Registry, and she is also a co-chair of the European Network of Cancer Registries. So, very welcome to all of you. The procedure here will be that, first of all, Marnar is going to have the opportunity to present his work, and he will have up to 1 hour, half an hour to do it. Then we will have questions from the first examiner, who is Henrik Møller. And after that, we will have a break for about 20 minutes. And if there is or are some extra auditorio, some people here who would like to put questions to or raise questions to Marnar, it's also possible. But if you have any questions, you need to notify me during the break. And then we'll take it from there. And if there is any extra auditorio, it will last maximum 40 minutes, and then we'll go ahead with the second examiner, who is Elisabeth van Eucken. If there is no extra auditorio questions, then we'll proceed right away from the coffee break with the second examiner. So, and when the examination is over, then the examiners are going to another room here in the building to find out if Marnar has passed his exam. This is, in fact, an exam. And they will be away for a few minutes. And I think it's better that we stay here while they are away, or at least just be close to here, because it's more easy to go ahead after their meeting. And after the meeting, the chair, Paul Verja, will announce announce the outcome from their votation. And if, as we hope, Marnar has passed the exam, we are ready to hand him his diploma, which I have the honor to do. So I think we are ready now to start. If I have remembered everything, just look into my list here. Yeah. So, please, Marnar, the floor is yours now. Thank you.
Thank you, and very warm welcome to all of you. Very nice to see so many. And a special welcome to the three of you, Professor Henrik Møller, Dr. Lisbeth van Eken, and Professor Paul Weije. I'm looking forward to being able to discuss my research with you. So just shortly to the audience, this is as mentioned in English. If some of you, I'll just switch to Faroese. Hvis Jan Kratikon vil lese en semandrott, så og i ritgerðene som printet, altså i 98 ber til at lese, hvis de vil lese om det her. Yes. So moving on, just shortly about the project. It's titled Cancer Epidemiology in the Faroe Islands. So it is about cancer quite broadly. And it is based on 4 articles, of which 2 have been published. My supervisors were grateful to you for your guidance and support throughout. They have been Maria Skalum Pettersen and Marenström. And I have been affiliated with the 4 institutions mentioned in the bottom, and I would also like to show my gratitude to the funders listed here on the right. So before I go ahead and get into the articles, I'd like to spend a little bit of time on talking about the data which has laid the groundwork for the articles. And that is largely based on the Faroese Cancer Registry. So the Faroese Cancer Registry was founded back in 1994, but includes cases back to 1960 through retrospective work that was performed at the time. And then afterwards, their cancer cases have been registered prospectively. Even before this project started, there were some indications that some cases might be unreported in the FCR, some cases might be missing. So that was one of the first focus points we had, was to look at what is the situation actually. Are there a lot of missing cases? And it ended up being quite a lot of effort going into this part of the project to make sure that the data we were actually using for articles is reliable. And also we wanted to secure better reporting in the future to see how we could ensure that. So in order to do that, I looked at what are the sources for the cancer registry. There are 4 main sources which are listed here. Clinician reports. A clinician who treats or takes care of a cancer patient is obligated to report it to the cancer registry in the Faroe Islands if they have not been reported previously. That is the main source, but there are also other sources. Pathology reports are used. Most, not all cancers will have some kind of pathology information. So that can be used for the cancer registry to identify cancer patients. Death certificates are also used, so if it's listed on their death certificate as a cause of death, that they died of a cancer, it is possible to identify the patients through that and get them included in the cancer registry. And fourthly, with electronic health systems, it's possible to do certain searches throughout all of the journals to identify further cancer patients. So in order to find if there were any missing patients and to see how I could improve the reporting, I went through these 4 sources. So starting with pathology reports. Pathology was available for all Faroese patients, but it was in an unorganized manner, such that it was in single word files on a computer. So it was not possible to do searches on it, or it wasn't set up like a database. So that was one of the things I started to work on, to take all of these more than 36,000 files and perform word search and text recognition algorithms on it to create a database from it, which could then be used to provide data for the cancer registry. And this was for the years 2007 to 2019 when this data was available. And from 2020, they have purchased a new system which will ensure that pathology going forward is in a registry database system, such that it can be used for the registry. And the second of these sources is death certificates. Previously, it was always performed in hand on paper forms, and then manually typed into a database with the Chief Medical Officer's office, and then sent to Denmark for validation, and first after all that it could be used for the cancer registry. This led to that there were some delays in using this, and for some years before we started, before this project started, there had not been any checks with death certificates. And also data from death certificates is used for performing mortality calculations. That wasn't available, but that's something we managed to acquire. And as a part of improving how it's going to be going in the future, we have partially shifted to electronic death certificates. At the hospital, they mainly use those now, and hopefully over time we will shift to electronic death certificates rather than on paper. And thirdly, the clinician reports. They were also quite manual how they were performed, either on paper or on PDF, but then printed and coded in manually. This is a laborious process, and we should, in my opinion, have a smarter process than this, an electronic process which automatically collects data into the cancer registry and can get some of the data automatically. This is an ongoing process. Unfortunately, it's not completed yet, but hopefully we will get there. And the fourth of these sources that I mentioned was the electronic health system. So this has not been systematically used previously. Previous to this project, there were some research projects where researchers would use the electronic health system, but then the data wouldn't always get back to the cancer registry. But through this project, we searched for back to 2006 when the electronic health system was initiated, and from now on it will be used to ensure that we can register as many as possible of cancer patients. The way that is performed is using a list of diagnoses. That's the main way, at least. So ICD-10 diagnoses, they are listed here. This is a long list. This is the list of cancer diagnoses which are required to be reported to the Danish cancer registry. So we used the same list, and just, you don't have to read it all. It's basically all C diagnosis and some D diagnosis, as well as a few others. So we used this and looked at all patients who had one of these diagnoses, and if they were previously registered in the cancer registry with a diagnosis of the same type, then we would exclude them. But all that weren't previously registered, I would look at their medical journal to see if they actually had a cancer or not. So all of these sources led to that I was able to identify some new cancer patients which hadn't previously been reported. The source I just mentioned with ICD-10 diagnosis codes is in the top blue. I found 389 new cases. It started with 754 patients, potential cancer cases, but when I looked at all of the medical journals, it ended up with being 389 new cases. I used the database I created for pathology to identify 105 new patients from that source. And I also used the electronic health systems with other, not just ICD-10 diagnoses, but if they had been registered to have visited the oncological department, for example, I would find all of those patients and see if they actually had a cancer. That yielded 27 new patients. And finally, by interviewing clinicians in the hospital, I was able to find some more patients through lists and patients they knew of that yielded 17 more patients. This all led to 538 cases, but as you see, it ended with 411. That's because some checks were performed afterwards. That's both, some were duplicate registrations due to, for example, the date of birth being wrong in the cancer registry, so it was actually the same patient that I identified again, or due to multiple primary checks. And you probably know this, what a multiple primary check is, but for the audience, it is possible to be registered with a cancer several times if you have a different cancer. So for example, you could have a breast cancer initially, and after some years, you would have a lung cancer. But there is a possibility that this lung cancer is actually a metastasis of the breast cancer. So you look at the morphology of the second cancer to see if it is the same. There are a whole set of rules which are performed, checks, which then will exclude some cases. So that's how we ended up with 411. This corresponds then for this period to 13% of cases being unreported through this period. So after I had performed this validation process, we believed that the data was ready to be used for the calculations needed for the articles. But one could of course ask, yes, there has been an improvement, but could there still be more missing patients? And of course we cannot be certain. There is a possibility of still lingering unreported cases. And one primary source that we need to, in my opinion, get as well is data from Danish healthcare registries, because a lot of patients in the Faroes are treated partially in Denmark. So a lot of information could be in those registries, but it's not just easy to get that information on Faroese patients, but that's something we're working on. Finally, before I get into the articles, I wanted to mention Nordkan as well, because that has also been a large part of this project. So Nordkan is a collaboration between the Nordic countries to show cancer statistics for all of the Nordic countries in a comparable fashion. There is a collaboration to present data in the same way. It's done using the same R codes, which means that the calculations are done in the exact same fashion so that you maximize comparability. And also there has been a work ongoing to harmonize registration practices so that comparability is maximized. And I have used Nordkan, where I have supplied data to Nordkan and then used it in my articles for some of the articles. Yeah. All right, so that was a short, maybe not so short, introduction. And now moving on to the articles. There are 4 articles in the thesis. They're listed here. I'd like to go through them very briefly. I'll start with the 4th article regarding COVID and cancer. So COVID, as we all know, hit us all during 2020, and this was while I was working on my project. So it was while I was doing the validation process with using the electronic health system, and we could see from research elsewhere that it seemed like the cancer incidence in many places was decreasing in the start of the pandemic. And this is probably not because of a true decrease in cancer cases, but rather because patients either didn't dare go to the doctor because they were afraid of getting infected, or they were prevented from being able to go to their doctor to get a diagnosis because of restrictions. And this would, of course, then lead to them probably just receiving a diagnosis later when their cancer perhaps was more advanced. So we felt it was important to see what was the situation like in the Faroe Islands. So what we did was we wanted timely data, so it was a bit too long to wait for cancer registry data. So we used the electronic health system. So I compared all new ICD-10 cancer diagnosis for a year compared to cancer diagnosis in the electronic health system previously. First for 2020 and then for the 4 previous years. The data was gathered in the same fashion, so it was comparable. And this is what it showed. This is the cancer incidence by month. And we're looking at the dark blue column, and maybe especially from March and April. And the other columns are the 4 previous years, and the green line is the mean for the 4 previous years. So if we were to expect to see the same thing as in the other countries, we would expect to see a lower incidence during March and April. But we actually see slightly higher than expected incidence. So this was a bit surprising that we didn't really see the same effect in the Faroe Islands. Why was that? It is perhaps because COVID also hit us quite differently than many other countries. We're an island country we were able to eliminate COVID. So maybe it didn't have the same effect here because we didn't have as much COVID. This is an example of why I believe, one of the reasons why I believe it's important to have a working cancer registry which can provide timely data and give the politicians something to actually decide to change policy on. If this had shown the opposite, it would say that we would probably need to do something to ensure that cancer patients are able to get to their doctor. On the other hand, this showed that what we're actually doing seems to be working. So moving on to the next article, I would like to take the article on childhood cancer. What we did was looking at childhood cancer from the Faroese, with basis from the Faroese Cancer Registry. But since all children with cancer in the Faroe Islands are treated in Denmark, we also used the Danish Childhood Cancer Registry to see if we could get some additional data there. Then we stratified the children into the 12 main groups according to the International Classification of Childhood Cancer. And this is one of the figures from the article. Each square represents one child with cancer in the years 1960 to 2019. This is 114 children. And what we see with just a quick glance is that this distribution is interesting. It's a bit different for the older children, and the distribution is different for the older children compared to the younger children. If we look at the younger children, we see that the largest group is brain and spinal tumors, which is also interesting because that's not what we see in most countries around us. Leukemias is the most common group, so it seems to be a bit different here. If we take a look at the incidence, this is age-standardized incidence such that it can be compared across different countries. I took the whole period from 1960 to 2019 and calculated the incidence rate here. And we see a 13.03 for all cancers for both sexes. In the Faroe Islands, well, it's a bit higher in most other countries around us. So it seems like perhaps we have a low incidence of childhood cancer in the Faroe Islands, which of course is very good. Yeah, that was childhood cancer very shortly. Then I'd like to move on to article number 1 about incidence and mortality. For this article, we used Nordcan data. So first we supplied data to Nordcan and then used it for the article, both to show the distribution over time in the Faroe Islands, but also to compare with the other Nordic countries. We used age-standardized rates, such that it can be compared both over time and across different countries. We also use 10-year periods rather than 1 year with small numbers, such as in the Faroe Islands. There is variability, but by combining 10-year periods, we reduce that somewhat. Just to give some background on the numbers, there are around 300 cases a year, perhaps a bit fewer, and around 100 cancer deaths a year in the Faroe Islands. So, yeah, what did it show when we look at incidence over time? This is for women from 1960, and the newest period is 2010 to 2019. These are only a selected few entities. I don't have time to go through it all, unfortunately. If we look at the top line with all cancers, we see a marked increase in incidence, a bit more than double from 1960 to the latest period. It should though be noted that data before 1978 is a bit doubtful how complete it is, since there's not pathology available for all cancers at that time. So, but even if we look only from 1980 to the newest period, we do see an increase in incidence. If we look at lung cancer for women, we do see an increase in incidence. Colon cancer, a small increase. Breast cancer, quite marked increase. And cervical cancer, yeah, it seems to decrease, but I'm a bit doubtful if that's a real or just a variability. And if we look for men, we see the same picture with all cancers, a marked increase, almost threefold. But again, if we only look from 1980, it's a bit less dramatic, but still an increase. It is interesting to look at lung cancer for men, because that incidence seems to be declining while it was increasing for women. Perhaps that's something to do with smoking in men, decreasing some years ago. Prostate cancer, we observe a marked increase, and testicular cancer also a marked increase in the last 20 years. Colon cancer also an increase in incidence. So if we move on and look at mortality over time, this goes back to 1983. That's when we have mortality data. Before that, it's not available, unfortunately. We see a small decrease, actually, in mortality for women in all cancers. While lung cancer, a small decrease. Breast cancer, a decrease in breast cancer incidence, even though during the same period there was a rather large increase in the incidence. And if we look at men, we also see for all cancers actually a decrease in mortality. For lung cancer, a decrease as well. Pancreatic cancer and esophagus cancer see a small increase in the mortality. So this was over time. Now I would like to go ahead and look at the comparisons to the other Nordic countries. This is then done for the previous 10 years, so 2010 to 2019. We calculate the worst incidence in the Faroe Islands, and the Nordkan countries is combined for all of the Nordic countries. And then we calculate the rate ratios and calculate confidence intervals to see if there's a significant difference. The incidence in women is lower than in the Nordic countries. It's quite interesting. If we look at specific sites, we can take malignant hematopoietic, seems to be lower as well. While, for example, rectum cancer is a bit higher, melanoma is lower, and the breast cancer is lower than in the Nordic countries. If we look at for men, all cancers are also lower, while esophagus and testicular cancer have a higher incidence in the Faroe Islands, and prostate and melanoma, for example, have a lower incidence than in the Nordic countries. If we then, this was incidence, if we then look at mortality, we see that the mortality is quite similar. This is for women, for all cancers, it's almost the same. Even though the incidence was lower, we see the same mortality. Breast cancer mortality was also quite similar. While ovarian and cervical cancer and kidney cancer all exhibit a relatively high mortality in women. For men, for all cancers, it's exactly the same mortality, again, even if the incidence is lower. Esophagus cancer and pancreatic cancer show a little bit higher mortality, while lung cancer is essentially the same. And testicular cancer, that's interesting that even though there were quite many cases in these years, there were no deaths during this 10-year period. So, yeah. And moving on to the final article in the thesis about survival. So here we again use Nordkan data, and we calculated age-standardized relative survival to be able to compare it across different countries. And it should be mentioned that the numbers are quite low, so this leads to some uncertainty with the estimates. That's why we do show confidence intervals for the Faroese estimate. I only show it for the Faroese estimate in these graphs. And also, it's worth mentioning that a change in Nordkan in 2019 with the update then made it so that normally you would combine 5-year age groups, 5-year time calendar years to a group and say how many of these patients survived 1 year and then 5 years. But since very low numbers give a lot of uncertainty, there have been set some standards in the program that you need at least this many patients in order to calculate the survival, otherwise it won't be calculated. So the change was that now, not only using 5-year calendar periods, it was changed to also use 10-year calendar periods, so the groupings will be larger, and therefore we are able to calculate it for more different entities. This is very beneficial to the Faroe Islands because otherwise it would be calculated for very few groups, And since this is done in the exact same manner in the other countries, this data is very comparable to the other countries. So this is the first time we can really show survival for the Faroe Islands and compare it to elsewhere. If we go ahead and look at the graphs, this is all sites, so a large group for women and for men. This is 1 year survival. We see that it starts around 50% in 1970. That means that if you were diagnosed in 1970 to 1974, after 1 year, there would be approximately a 50% chance that you were still alive. And then it increases to around 75, a bit above that in the latest period. This is 1 year survival, this is 5 year survival. It's the same picture, it's increasing over time, but it's a bit lower for 5 year survival. And we see, I should mention that the Faroe Islands are the red dots with the light red ribbon around it. And we see that the Faroe Islands followed the trend in the other countries that the survival is increasing, though the Faroe Islands are lower in all time points, which indicates that the survival somehow is a bit worse for Faroese cancer patients. If we look at some single sites, we can look at breast cancer, which is a large group, of course. I think this graph is very interesting. I'd like you to look at the 5 year survival. If you look at the time period 2005 to 2009, and then the next one, we see a marked increase in survival. So it seems like something improved there. If you look at what actually happened during that time period, before that, cancer treatment for breast cancer wasn't as organized as it is now. During that period, it became standardized treatment and specialized surgeons who performed the surgery, which seems to have given an improvement to the women who develop breast cancer. This also, I think, is a great example of why it's important to have working cancer registries which regularly report data, because if this was known at the time, this could probably have led to some action by the politicians to improve this, to get better outcome. Moving on, I'd like to show you 2 more graphs from this article. Ovarian cancer. These are just some of the graphs which show some interesting results. There are, of course, many graphs in the article itself. Ovarian cancer, 5 year survival women seem to have a quite low survival here. Of course, the confidence intervals are wide, but this indicates that this is something that should be looked at. How come they exhibit a lower survival? And this is, in fact, a research project we're working on to see if we can identify some reason for this. And also the same for lung cancer in men. Again, look at the 5 year survival. It's a bit difficult to see here because it's all truncated in the bottom, but the Faroese men exhibit a lower survival. It had been talked about previously that Finnish men needed to look at why they had a lower survival than the other Nordic countries. And then we go ahead and we find that we have an even lower survival than Finnish men. So it's definitely something worth looking at. Yes, I'd like to have a some short points on discussion, because there are some differences that we observe in the data, and is there an explanation for these differences? One thing that could explain some of it is persistent underreporting. Is there still some underreporting going on even if we have tried to validate it? Possibly, but it can definitely not explain everything. The sites where we see a higher incidence in the Faroes will not be affected by underreporting. Could one imagine that there are specific risk factors to the Faroese population which would lead to differences in incidence, for example? Yes, that is possible to imagine. One could say that the genetics of the Faroese population is quite homogeneous, which could lead to an increased risk for some diseases while a lower risk for other diseases. That could perhaps explain some of it. Pollution could also explain some differences, as air pollution, for example, in the Faroe Islands is quite low, while we have some exposure to other pollutants such as mercury, PFO, PFAS, from the seafood that the Faroese people have intaken a lot of, and whaling, and so on. yeah, the time is flying, so I'd like to just give some perspectives on how I see what lies ahead for the Faroese Cancer Registry. I think that the NordCan collaboration is crucial for the Faroese Cancer Registry, both as it provides opportunity for development within the cancer registry and sparring with other countries to develop our skills, but also to have the direct comparisons with the other Nordic countries, which can provide us some quite valuable information. I would really like to work on being able to getting Danish health registry data about Faroese patients available in the Faroe Islands. I think that would go far to ensure that the quality is as good as it gets, and that could perhaps also lead us to have better information about treatment variables and stage variables, as that information is sometimes lost if it is in Denmark. And finally, I would like to say that we need to prevent the need for another project of this kind in the future, in 10 years' time. We need to ensure the cancer registry has proper and complete registration of cancer patients, so we can continue to report on this data and research in this area. So a final slide with some acknowledgements, probably many more that could be mentioned here. But yeah, that concludes my short presentation of my thesis. Thank you.
Thank you very much, Marnar. Then I give the floor to Professor Møller.
Ladies and gentlemen, Marnar, we're going to have a conversation. I don't want you flying around over there. Firstly, Marnar, I would like to thank you for investing yourself in this and for committing your time to all this work. It's a big effort, and it's a pleasure to watch. So thank you for that, and welcome to the community of cancer registration, which is a pretty friendly bunch, actually. There's about 1,000 of us, I think, in the world, and many of us know each other. And I see you navigating your way into that community, not least by hosting the conference of the Association of the Nordic Cancer Registries next week and so on, which is a big event. And I think the coincidence of your defense and your hosting that organized is very fortunate. So well done that. The business of cancer registration as a subset of cancer epidemiology, both public health cancer epidemiology and academic cancer epidemiology, is very much the foundation of what we do, and it has implications a long way forward into cancer policy and sort of healthcare big decisions at the very administrative and political levels. I guess the reason we have, our forefathers in cancer epidemiology decided to start cancer registration. I can try that, yeah, sorry. Our forefathers in this industry started to convene and discuss how are we going to go about this work. And decision was made on creating cancer registers internationally. At the same time as the cardiovascular epidemiologists started putting people on exercise bicycles and drawing bloods and all that stuff. So I mean, it's also opposing strategies to find out about these diseases. In recent years, I think the cancer survival part of this vital statistics exercise has become increasingly more influential in cancer politics and cancer sort of healthcare policy than the incidence trends. Certainly, Elspeth and I both come from communities in Belgium, and in my case from the UK, where the demand for cancer outcomes epidemiology far exceeded the demand for cancer occurrence epidemiology. And I also see you in your own work here in the Faroe Islands sort of encompassing both with emphasis both on cancer survival statistics as an outcome, but also alongside the incidence. And my prediction is that you're going to end up doing more of that. I think the way Elspeth and I have divided the work between us, and we actually didn't sit down and divide the work, but as it turns out, you will probably find that my comments would be rather on a generalist level, as I already started, and Elspeth will probably also dive more directly into the business and the practice of cancer registration. So expect a mixture of both. I guess my principal interest in your thesis and in your research work pivots around the incidence statistics and the survival statistics, and there's a couple of things in that I'd like to discuss with you. So if you think back to the sequence of pages in your thesis which are largely the tabular material, where you look at the incidence trends and the comparison with the Nordic countries, a lot of my interest pivots around that. And the challenge I see from experience, and I see that in your work also, it is a challenge for the vital statistician, as we are in a sense, to be confronted with this diversity and this volume of statistically computed rates and so on, and then deriving at a concise narrative that actually wants to say what is the situation about the burden of cancer in the Faroe Islands. So obviously you don't want to throw 6 pages of tables on the floor to answer that question. You want to arrive at a narrative. And there's a few things about your arrival at your narrative that I kind of would challenge. And so there would be a couple of thoughts along that line. And if I may begin with your decision to arrange your analysis alongside the separation of these diseases in men and women. So you choose to show us a table of stats in the female population first, then the male afterwards. And I wonder why you do that. I mean, why not start with the combination of men and women where it makes sense? I mean, I'm aware it doesn't make sense in many of the diseases that you describe to us, but why not start with a statement about colon cancer or rectum cancer, and then secondly, ask yourself whether this is similar for the male and the female part, because you have a problem with small numbers to the answer. That's the conditions of your work. You're not making that easier for yourself by deciding to be stratifying from step one.
Mm-hmm. Yeah, that's a good question. The answer, I guess, is quite straightforward. I relied heavily on NordCan and the NordCan calculations, and this was how it is done in NordCan. And rather than also calculating that by myself, I could have done that. I decided to continue to use the same metrics, which are also used in the other countries, and then facilitate the comparisons.
I see. So it's a kind of that's a bit unfortunate, because that means that the practical way the NordCan analysis package is configured actually paints you up in a corner where you have to do it in that sequence.
But it's an interesting question, because I'm also a part of the NordCan working group. So that is something that I could take up, and I have been thinking about many alterations that we could do to the NordCan calculations, and that would definitely be one thing we could add, to combine men and women as a possibility, because the way that NordCan works, it allows you a lot of different possibilities. So adding that would not be difficult, and it would be an interesting addition. Yeah,
I think it may be particularly an issue in the small and beautiful community that you service. I mean, Elspeth manages a cancer register in a 9 million population or thereabouts. 11 actually. And I used to work with the 14 million population of cancer registration in London. So we actually never had any big difficulty with numbers. We had lots of difficulties with everything else, but small numbers weren't the typical concern, which it inevitably is here. Your comparison with I kind of skipped to, I'm probably going to return to the incidents, but skipping to the comparison with external evidence. You know, you compare yourself in terms of the rates, you compare your rates with the aggregate Nordcan rates in order to have a reference population. I mean, in order to have some idea of the expected rates from external. I wonder why you decided to pool the Nordic population with ex-Faroe Islands. I mean, compare yourself with the rest of the Nordic countries. Why that choice? Why? I mean, an alternative would be particularly if you think about the context of cancer care and the organization of oncology and so on. Perhaps a more natural comparison would be with Denmark.
Yeah, that is something that I also considered, but we talked a bit previously about feeling like a part of Denmark, and that would, I think
this was not a colonial motivated statement, you know.
I think it would also, we could have perhaps decided to do it with Denmark and Nordcan. I think it would feel strange to only compare with Denmark. Yeah, also, since we're using Nordcan, so why only look at Denmark? It's not only in Denmark that interesting things are happening. Also, I think with the treatment happening in Denmark, that would probably not affect the incidence that much. So it would be some, if we wanted to compare with Denmark, it would be some hypothesis that we are more like Danes than Norwegians, for example. And I'm not sure that I'm certain that we are more like Danes than Norwegian people, for example.
Okay. I take that point, absolutely. If you think of, let's dive into one of your particular comparisons, and you have a particular interest in testicular cancer, which is actually an interest that I share very deeply. The comparison between your principal interest, the Faroe Islands populations, with the aggregate of the other Nordic countries. I mean, I don't want to be rude, but you could almost say that that is a silly thing to do when you look at the variation between the other Nordic countries in the rates of testis cancer. Finland has got very low rates. Yeah. Denmark and Norway have got very high rates. What does the average of that mean? Yeah, why not include China? You know, I mean, it's.
Yeah, that's a good question.
I mean, the point is the point is not that is not really a rational basis of deciding what the expectation would be.
The one thing there, I guess, is that since I'm doing it for so many cancers at the same time, it would be difficult to say for testicular cancer I want to compare with Norway, and for breast cancer I want to compare with Greenland or something else of the kind. So therefore we decided to do it for the Nordic countries for all of the cancers. But we're of course thinking, as you mentioned, testicular cancer is interesting in the Faroe Islands. It seems like we have a high rate. So if we were to go ahead and write an article specifically about that, that would be something which we would include. And also in the supplementary tables for Article 1, we do show comparisons for each country to the Nordcan rate. So we can see there a bit an indirect comparisons with Norway and Denmark, which have a higher rate than the Nordcan. That's true, but not as high as in the Faroe Islands.
Right. And I'm returning to my challenge of, you know, how to go about synthesizing the information in your case in 6 or 8 pages of tabular material. So this vital statistician's challenge in creating a narrative that summarizes what you really want to say on the basis of these numbers. And if I looked up it really is an issue of dimensionality. If I look at the tabular material where you deal with occurrence of things as opposed to survival, you have dimensions of 2 sexes. We can still talk of sexes. It's falling out of fashion to speak of 2 sexes these days, but let's maintain that terminology now. 2 sexes, 20 or so, 20 plus a little bit disease entities, 4 periods, alongside, and then 2 outcome measures, incidence and mortality. That's the magnitude of the dimensionality of that's 300 entities in combinations of all that, which is an awful lot. And if you kind of decided a priori to start with the combination of men and women, that doesn't reduce that dimension from 2 to 1, but sort of from 2 to 1.5 or thereabouts because of the sex-specific sites. But the 4 periods, you could have combined into a single assessment of a trend over time. That reduces 4 dimensions to 1. The incidence and mortality are really not they're really synonymous ways of looking at something. The incidence rates of lung cancer and the incidence of lung cancer death, which is what lung cancer mortality is, are really measures of the same thing. And if you would accept this sort of way of reducing the dimensionality of your tables, you actually end up with less than 25 dimensions as opposed to more than 300. So that might be a way to go about reducing it. I've had the challenge of that, and you will get such challenges too, because one day you will be confronted with a set of tables for Faroe Islands, and a set of tables for Norway, and a set of tables for Sweden, and a set of tables for another number of countries, and creating this narrative systematically for each of those. It's bloody difficult, and it's horribly boring when you start doing it. I say, how am I going to create this text or this summary of things? And the idea of reducing dimensionality of things is one possible way of going about it. One thing that struck me, another interest I've had since I was very young was, apart from testis cancer, was in stomach cancer. You didn't seem to make much noise of the reducing rates of gastric cancer in the Faroe Islands, which is an interesting universal thing almost.
Yeah, I'll just go ahead and find the table. So you're interested in oh, it's locked out. You're interested in stomach cancer, the comparison, or over time?
Over time.
Over time. If I remember correctly, the numbers are lower for stomach cancer, but I might be misremembering. No. Yeah. Let's show it for the audience here. So we're looking at stomach cancer over time, right?
Yeah.
Yeah, that's true. There's a marked decrease in the incidence, and that's even as before 1978, when I said that there was an underreporting, so perhaps even higher than that, which is very interesting. Yeah, yeah, I could have probably spent more time on that.
I want you to keep that slide on the wall, because that actually reminds me of something else I really didn't like about your thesis, if I may be blunt. To your left, you have these aggregations of things that you might call tracts, the digestive tract or the urinary tract and so on. And onto the right, you have the entities that probably more resemble what would be etiological entities, certainly much closer. I mean, I wonder what your reason for both showing these tract aggregations and the individual side. Why did you settle for showing those? I think I would have showed only the ones to the right.
So I understand also your question before regarding the dimensionality. I think my going into this was there isn't really any reporting on systematic reporting on cancer in the Faroe Islands. No. So therefore, I wanted to be very broad and include as much as possible. So these groupings here, as you mentioned, they are the groupings which are present in the NordCan website and how they are presented there. So I used those groupings, and then I included not all single entities, but most of which I thought were interesting. So that's a short answer to why this is set up as it is, and that was my focus to try to be very broad, since this is perhaps the only time an article of this kind is going to be written about cancer in the Faroe Islands.
Right. I mean, I hope you appreciate that some of those things are too similar. I mean, the entity to the left called the respiratory system is effectively the same as the entity to your right called lung.
Yeah,
The entity to your left called skin is something very different from the melanoma on the right. And there's another kind of skin cancer, which is the two sort of principal non-melanoma skin cancer types, didn't make it into to the right side, although they are more common than the melanoma. You know, why these kind of...
Yeah, but in order
is that Nordcan again that does it for you?
No, it isn't. In order to skin cancer, melanoma is here, right?
Yeah.
So in order to gather the non-melanoma, you can subtract the melanoma from the skin group. So in order to not repeat myself, perhaps, I decided to not include the other one. And as you mentioned in one of your comments, this was not clear in the thesis beforehand that skin cancer does not include the basal cell carcinoma.
Okay.
That is also a part of the Nordcan way of calculating the incidence of these.
Okay. So the difference would be squamous cell carcinoma of the skin.
Exactly.
Which is not an uninteresting entity in its own right also. Okay, a reflection on the two smaller chapters in your thesis, the one on childhood cancer. Marnar, what I observed from your table and indeed from what I thought I knew already about childhood cancer, which isn't a lot, is that this is a category of malignancies that actually varies very little between communities and internationally. And I found that again also in your columns of the different Nordic countries. The odd one out, the exception to that was the Faroe Islands with very low rates. I mean, I cannot, and we're going back a long way into the era where you have a concern about under-ascertainment. Wouldn't it be much more likely that the low rate of childhood cancer in the Faroes in this period is all under-ascertainment rather than a genuinely lower rate?
No, I actually don't agree, because childhood cancer, children with cancer, they get sick and they get diagnosed, and since there are so few, the doctors remember all of the children that have cancer. So this is something that will probably be quite well registered. But you are of course correct that since all of the treatment is given in Denmark, there is a risk that some might be missing from our database. That was why we chose to include the Danish Childhood Cancer Registry. But what actually happened was that I only found 2 additional in that registry. So I was a priori perhaps expecting to find more, but since I only found 2, that perhaps makes me a bit more sure that this is perhaps actually how the picture is.
Okay. Interesting. But you do appreciate we are going back to the 60s with that time series?
Yeah. But in the table in the article, there's also a stratification over 10-year periods. I can find it.
Yeah, please do. That's good.
Oh, I'm sorry, I don't have it right here.
But tell us what it shows. That's fine.
Yeah, I'll find it. So if we take the latest period for both sexes, it's 12.23 for 2010 to 2009. I have it on the computer. Should I show it?
No, I think we'll take your word for it for now. But it's fair.
It's on page 185.
Excellent. Okay, and another reflection I have on the final chapter, the COVID and cancer chapter, an observation, and what you observe is that COVID did very little to the registration of cancer in the Faroe Islands. I would submit to you that is probably in retrospect now, when we are on the good end of the corona pandemic, is probably that it actually didn't change an awful lot. And I will challenge the other publications that you refer to some of them at least, sort of supposedly showing an important reduction in the registration of cancer in that period. You see what happens, and that certainly happened also in the London Cancer Registry, and I think it happens everywhere, that due to the process of cancer registration and ascertainment of cases, the situation is always that your most recent period is under-ascertained. So when you sort of formally declare that now the London Cancer Register is updated with yet another year, and you push out an annual report and you feel great, when you come back a year after and you recalculate the incidence for last year, it's certainly 5% higher.
But if I might challenge that a bit, that depends, of course, on how you gather the data. That is correct if you use cancer registry data, but that is not what we did here. We used diagnosis in the electronic health system. And for the years previous, we did it in the exact same manner. So we would expect if there was a lag in diagnosis, that would also happen for the years previous. So it is at least something that we try to do in a way that avoided that bias.
That's a fair point. That's a fair point. I think the Danish evidence, which I know superficially, and actually only superficially, in the circles that surround me, we actually don't believe that Corona changed cancer registration incidence importantly in Denmark, but we are aware of an artifact along the lines that I suggested to you.
So just to, I am a part of I'm a co-author of this paper here, which is a comparison across all of the Nordic countries. What we did here was look at the pathology reports.
Okay.
So this again is another way of going around this with lag in cancer registries. We see that for all of the countries except for the Faroe Islands during March and April, there is a decrease in new malignant pathologies reported to the pathology labs. You could perhaps argue on the other side that they are slower in performing it or something, but I think this seems to indicate that there is an actual decrease during at least those 2 months. While for the Faroes in the bottom right here, it's a bit chaotic with small numbers, large uncertainties, but there is no decrease in pathology in the early periods. No,
this is very impressive. I probably exaggerated what I was getting into there. I mean that evidence is as strong as you suggest, I guess. My own observation in the little cancer incidence monitoring I do nowadays is in prostate cancer, where in Denmark, in fact, in April and May 2020, there was a marked deficit in registrations of prostate cancer. But our thinking along the lines of that was really that what happened in that period, and this is speculation, what might have happened in that period was that the activity of going to the doctor and having PSA tests declined, and the incidence didn't seem to be compensated later on. So we actually thought, along with the urologist, that the more likely narrative again for that was probably that some hundreds of men were lucky that they didn't have a PSA test in that period and didn't have a largely unnecessary prostate cancer diagnosis. But that's, of course, a flip side of what you're talking about there, and something exceptional to prostate cancer. Probably.
Yeah, and that's one reason why this is very relevant to try to follow over time. How will it be during 2021? Will those diagnosed actually have a later stage than those diagnosed previously, because they should have been diagnosed in 2020 but weren't? And the article I showed before showed also a difference in countries. Did they catch up to the expected rate?
Sure.
And most countries almost caught up, but Sweden, for example, were quite a bit still below the expected rate. So it will be relevant to look at the years following to see, will there be a difference?
And you won't see it, because whatever happens in terms of compensation in the future after a sharp deficit, possibly, and I agree, there's a deficit in pathology in those months. I mean, whatever compensation happens after that will be diluted over a longer period of time, and you will never see it.
Yeah.
Sorry.
You're probably right. Yeah.
No, don't even look for it, because you won't see it. Now, a final line of thinking I have with you, Marnar, is just pausing on the observation of relatively low cancer survival in the Faroe Islands population, and in a way, I'll challenge your layout of information a little bit. And I understand the need or the desire for have a uniform presentation with survival functions or survival estimates being sort of on a scale that goes from 0 to 100, but it does obscure things a little bit. And I mean, showing something that cruises at 8 to 10 to 14% between countries on a 0 to 100 scale is probably the old trick in the book of showing that this thing doesn't really vary. Don't worry about it because it's all the same. And you could easily change that axis to show a lot of variation if you wanted to. So that you can cheat with figures, and these are the classical ways of doing it.
But is the thing I'm doing not the opposite of cheating? I'm showing the whole.
No. Cheating depends on what your interests are, and I actually don't challenge you to have a particular interest in this. But the point I'm making is that had that axis being scaled to sort of accommodate the data rather than accommodate the 0 to 100 range, you would see something else. It would be an argument for the existence of variation rather than an argument for little variation. I mean, the bottom line is that the cancer survival in overall and for some of the diseases you showed is low in the Faroe Islands compared with the other Nordic countries. And obviously that is a challenge for an affluent community like this one. I mean, I come into Faroe Islands, it's my first time here. I see an affluent community. I see modern buildings, I see expensive cars, I see nice suits, I see healthy people, and I even see that people salute each other on the morning at 7 o'clock when we go to the baker. You don't pass anyone in the street without saying good morning. I find that quite wonderful, An affluent community, it's not just the good mornings that does this, but an affluent community would want to have the same cancer survival as the others, perhaps higher. Why not higher?
Why not higher? Yeah, exactly.
And so I mean, my thinking along that line is then talk to us a little bit and remind us in what way cancer care services, and I speak all the way from pathology, surgery, medical treatment, end-of-life care, whatever, because there is a collaboration on those things between the Faroese community and the Danish community. How is that organized, and where is that going?
Definitely. I can talk a bit about that. So generally, guidelines both for treatment and diagnosis are based on Danish guidelines. Most doctors who work in the various health sector have their education from Denmark, so we have very close bonds also with colonial bonds. So yeah, there are a lot of similarities, and also since we are so small, we will have a limited amount of doctors and also a limited amount of patients. So there is a limited degree of specialization a doctor can undergo. So therefore, we cannot provide very specialized treatment. And generally, when that specialized treatment is needed, the patients go to Denmark. So there is a very close connection. Some patients have previously gotten some of their treatment in Iceland. And we have also had some Swedish oncologists here for a period, but mostly it's in Denmark. But there are some small differences. In Denmark, previously there were several papers which admitted the fact that the Danish cancer survival was lower than the other Nordic countries, and lower than in England as well, or the same, I think, as both England and Denmark were quite low.
Absolutely.
So this led to a quite large effort to try to improve the survival in Denmark, and one part of this was the accelerated cancer patient pathways to ensure that the time from suspicion of a cancer to a diagnosis and from diagnosis to treatment is very low as possible. And this part is has not been implemented in the Faroe Islands. So even though after you have received the diagnosis, you will receive the same treatment as in Denmark, there are not the same requirements for the fast process otherwise. Yeah, what more could I say about that?
I have a curveball I want to throw you because I do clinical quality work these days.
Yeah.
And one of the things that occupies me is the quality of prostate cancer treatment in hospitals. And in the course of that work, I looked at data from the smallest region in Denmark, where the hospital in Aalborg is providing oncology, radiation oncology services for their regional population and for the Faroe Islands. I mean, Aalborg is definitely not the easiest place in Denmark to get to if you fly in from the Faroe Islands. So how did Aalborg end up providing radiation oncology services for the Faroe Islands? Do you know?
It's for breast cancer patients specifically. There is previously they were treated in Iceland, and now they have got an arrangement with Aalborg Hospital. Exactly why I can't really speak to that. That's probably both political and maybe circumstance. I'm not sure.
Personal knowledge of people in the other end?
Yeah, I'm not. I don't really know why exactly Aalborg was chosen.
As I said, it's not the easiest place to go to if you fly in from the Faroe Islands, but it's probably a place that provides excellent services. So I wouldn't discourage it. So
yeah.
okay.
One additional thing regarding the differences between the Faroe Islands and Denmark. Even if we were to implement accelerated cancer patient pathways in the Faroe Islands, there could perhaps be still some delay compared to Denmark, because there is the geographical isolation. It is perhaps only 1 or 2 days, but in some cases that over the whole group could actually maybe have a small effect. So even if we do a really large effort into this, it's not certain that we will get all the way up to.
Okay. Thank you. Dean, that concludes my opposition.
Thank you very much, Professor Marnar. Vi kan jo ha en eksakt, har vi kunnet si før, som i meste lei 20 minutter. Og som vi nevnte, så det mulig at sette spurningar at nå, fra tekkarsøye. Og om noen som vil sette Marnar spurningar, så må det selv være i samband med ritgerðnasjonen. Hva nå? Det vi kunne være interessant å finne noen politiske diskusjoner og alt det, men det er det. Og så vi stekker nå 20 minutter og kommer etter. Okay. Við fara the verja after. So I've got no questions from ex-auditoria. So we are going to proceed right away. And I will give the word to Dr. Eichen.
Thank you very much, Mr. Dean. Thank you for the invitation, Mr. Chairman, and also Professor Moller. First, I enjoyed your presentation. That was very clear. And I also enjoyed your conversation. So I'm happy that you are reaching this table to continue that conversation. I have another kind of questions for you than Professor Muller. But I hope that you will like them too, because you are tackling them with a kind of ease, which is nice to see. This is because you're into the materials, you know what you're doing. And what I appreciated also is that you are writing, you are working even with machine learning and regular expressions, you are working with epidemiological parameters, you are even going into some politics and addressing the future, which is also very important, I think. And we cannot forget for whom we are doing this. This is for the patient. Yes. I think this is the first thing also which I felt in your presentations through it. And we have a lot of stakeholders. So a cancer registry, if you look at the stakeholders, we are many. We have many. So we have the clinicians, which you are also, if I well understood. Yes. The hospitals, we have the researchers, we have, let's not forget the authorities. We have the public, the patient. So I think that you did there really a huge job in doing this. So my appreciation for that, and I wanted to say that even before all is closed, but this is really a huge work. I realize it because maybe some years ago I was in a kind of same position as you were, but then for a bit of more population. So that huge effort that you also mention in your thesis is about case finding, case ascertainment, trying to tackle the underreported cases. You have done that, so that was very, very important for me. What I missed a bit, that was to strengthen that. Maybe I would have expected some more quantification of that evaluation of your data. And could you maybe first try to explain a bit why you did not go into detail to quantify a bit more on evaluation of quality of the data? Quality in a broad sense.
Yeah.
Yes,
sure.
please.
So a challenge with both the thesis and the articles is that they need to be brief. And I think the thesis is quite long already. So that's definitely one of the reasons that I didn't really focus that much on providing more information about that. But we did do a bit more than what we show. We did calculate, for example, mortality to incidence ratios, which can be an indication of underreporting if the mortality is relatively high to the incidence reported. Otherwise, it could also be an indication of lower survival. So that's something we looked at, but for article number 1, we felt we had already so many tables that we didn't want to include that as well. But I'd add to that in the NordCan collaboration, some of the quality parameters are calculated. So that is something that we should probably look at, also reporting that some more. And one thing that I've been thinking about this particular topic is that we're still missing one major source before the data validation process is complete. I still really like to gather data from the Danish health registries on Faroese cancer patients. Yeah. So perhaps if we complete that, if we manage to do that, we have a meeting in 2 weeks' time actually with representatives from the Danish authorities, where we hope to gain some kind of agreement on that. Mm-hmm. Perhaps we would then write an article focusing on this aspect, where we could go a bit more into detail in this.
And you're telling about now about completeness. You use a bit completeness and coverage throughout the text. Could you maybe give the difference between the two, because this is very important. When you're speaking about coverage, you're speaking about something a bit different than...
Yeah, this is probably one of the areas where I have been self-taught in this area.
Yeah.
I don't really have that many older colleagues who can guide, so I've tried to navigate, and perhaps I am misusing some of the terms in some cases.
Okay, but you're covering the Faroe Islands, all the population you have
the
in
whole
that.
population is covered, but
Yeah,
the completeness is perhaps lacking in
so
some cases.
I see that you want to push a bit further on completeness if time and if you are able to do so. You're looking at mortality incidence rates. You will have the Danish health registries maybe to be included. Do you have any particular evaluation you would like to look at?
I mean, one important thing that I haven't focused much on is the stage variable. I haven't done much stratification on stage within cancer types. One of the reasons why I haven't focused on that is because I see in the data that the stage variable is quite incomplete in some cases.
Could you please comment on stage, because that was one of my questions that you wanted to ask. What do you mean by stage? Because you mention it in the table and it's only stage. What do you use for stage?
Yeah,
That's my first.
There are some different, I don't remember them all now, but TNM is one of them, and then there are an arbor for some hematological.
Yeah. So using really the classic TNM classifications for, you're not using a kind of extent of disease that is...
in the what we strive to do is to since we are so small, we try to lean on our neighbors to how are they doing things, and we strive to do things the same way, so we don't have to think invent the deep what's it called, plate again.
Yeah.
So we try to do it in the same manner as they do it in the other registries.
And you were speaking about, and that's maybe also what I mean by documenting a bit or quantifying a bit your missing values, because you state somewhere that the stage, but it was rather vague, that it was not so good historically seen, but now that it's getting better. What do you mean by missing values there? In which range or what range are we looking at? Do you have an idea of that? Because that would allow you to include it for some more.
Yeah, I haven't really looked into detail on how much is missing, but you have the opportunity to use, I think it's 9 for missing, and I just have observed that there are quite a lot of 9s.
Mm-hmm. And what would you like to do with that stage, for example? In which subjects would you really like to treat?
So if we take lung cancer, for example, which is one thing we're trying to look at now, they will undergo MDT, multidisciplinary conference in Denmark. And in that during that conference, the stage will be, the TNM, will be systematically registered. So that is one of the things I have been thinking. If we gain access to the Danish health registries, where this hopefully would be registered, this is something that we could systematically put into the cancer registry for already existing patients. So we could gain this, gain more completeness for this variable. And this is also I think one of the reasons why it is incomplete, because it is not readily available always. I mean, you could go through and look at for this cancer, what are the criteria for doing that, but that's not always what the doctor will do if he has a busy schedule and it's not listed right there.
So it's a matter of capturing the data, because I assume that if you're following the standards and the guidelines for diagnosis and treatment, that you are really working with TNM, for example. I mean, the doctors, the oncologists, the radiation oncologist, surgical people, I assume that it should be available.
Yeah, but again, much of it is available in Denmark.
Okay.
And not necessarily in our journal. And if it is often in a scanned PDF, which is not something we can use for
easily
searching in.
No.
So, yeah. But one possibility of doing it is because we have some disadvantages with being small. It is difficult to draw certain conclusions to the uncertainties,
Yeah.
but one advantage is that there aren't that many cases.
Yeah. And could you go a level higher in what kind of evaluations you would like to use stage? If you could restart your...
Yeah, just to finish
yeah.
my thought about the low numbers, that it allows for us to maybe initiate a project where we actually go through all of the patients and register it by going through their journal. That's something, if I'm of course not controlling the money, but if I was, that would be probably something that we could think about. But your question was how we would use...
Level up, so in what kind of analysis would you have liked to use your stage? If you could restart your articles, for example, where would you have liked to use stage? Or maybe in another article you can choose.
So, for example, with the survival calculations, it would be interesting to see is the reason why, let's take ovarian cancer, why the survival seems to be lower for 5 years. Is it because they're all diagnosed at a later stage? And that would then indicate that perhaps we should change something so it's easier to get a diagnosis for ovarian cancer. So that would be
That
at
would
least...
Okay, and I think you have also screening programs.
Yeah.
First, I thought that you did not include carcinoma in situ for breast and for cervix, but I saw on your slide that you have put it into your inclusion criteria for the selection of the electronic health system, I think, and for capturing for pathology. What about screening?
So screening, we have currently cervical cancer screening in the Faroe Islands, which started in 1995. So that has been ongoing for quite some time. And then we have mammography screening, which started in 2017. So that's quite recently. So it hasn't really affected probably neither the survival nor the incidence, which I show here because...
Stage distribution?
Yeah, that perhaps it could have affected that. But,
you would like to see a stage shift?
I'd like to see a lower stage now because we diagnosed them earlier.
Yeah, your survival increased for cervix. I'm sorry, I'm speaking about incidence now. Your cervical cancer incidence dropped the latest years.
That's right.
Do you have any idea about that?
No, not really. And you might be thinking about HPV vaccination, but that started in 2008 around.
That's too early.
So I don't really think that it has had that large effect yet. It will, of course, have an effect in the future, but probably not that large an effect yet. And a screening program will probably not decrease the incidence of cervical cancer. It would just mean that that's not true necessarily. We could catch some pre-malignant and then treat it, and thereby lowering. So that's, I'm just changing my mind as I speak.
You're changing. Yeah. Okay, so let's say we can speak in terms of comparability, we can speak in terms of validity. I have some punctual questions on, so you did not organize an internal check, let's say, you used the check of the NordCan system to look at the classic cross checks, or did you do that yourself? Did you organize it yourself? And what about questions? How did you solve the questions when it came out?
Could you explain what you mean about classical checks?
The checks I mean for topo, morphology, age, and let's say if it's applicable or not, if it's fairly known as such or not. If it's correct, if you don't have prostate cancer in female persons, etc.
Yeah, so it's partially what I did myself, some of but also in the NordCan R code, there are some checks included in that. So it will run some of the checks with the data that I provide for it.
Okay.
And then give some feedback to me, which I then can look at. This looks weird. This patient has the diagnosis before the date of birth. So
yes,
that's,
for example.
All of that is done through the R program and then feeds it back to me, and I can go check, it's because the date of birth is wrong for this patient. I can identify that and then fix it.
Okay.
Or if it's not fixable, then the patient will probably be excluded.
Yeah. About this also, these checks, did you look at microscopic verification? Because you could look there also if you miss cases that have maybe no microscopic confirmation. And I did not see immediately the difference between microscopic versus macroscopic. Is that what you mean, a technical or a clinical diagnosis? Or?
Both those are included. And then, yeah, there is, in the art program, there's also a microscopic how many are microscopically verified. We have a challenge there that if we go, again, something I observed in the data, if we go far back, it is quite often only registered as, with the SNOMED code M80003. So it's
just cancer.
Just cancer, exactly. And that was one of the things that I was then able to for the database I created from 2006 and forward, yeah. I can then go in and if this is 80,003, I can use the correct one in the database, so I can actually correct the morphology. And if we go further back, the previous pathologist who was here, he actually did a huge work on looking at all historical pathology samples in the Faroe Islands going back to 1978, when we have them, and he has gone through every single one of them and written in hand a SNOMED code. And this is then something that's currently being read into a database manually, so in some time then we can use that to have a better picture of the morphology, also going back to 1978. Thanks,
okay. I wanted to ask also about the DCOs. You said before 2015 it was not done after that. So do you have any idea of the percentage of DCOs before that time?
Yeah, I have a slide about that. So there are some DCOs in the Faroe Islands, especially going back. But we have more of what we would call DCI, so death certificate initiated. Because we have full access to the journal, what would happen is if we were to find a diagnosis from a death certificate, then we would go through the journal and register all of the other things afterwards. So it would not be a death certificate only, but a death certificate initiated. Okay. And perhaps you're interested in saying how many DCIs do you have, and unfortunately I don't think I know. I don't think it's registered whether it's a DCI, unfortunately. So there are some DCOs. If I look at my data, far back there are some. But currently there are very few. It's more DCIs.
There should be very few, and that could be an indication also of your completeness. Okay, the under-registration you said, or the under-reporting, you mentioned also that it was especially in male urogenital tumors, and also in brain. Do you have any idea why? Because I think that this was an important percentage of the cases you found.
Yes. So the Faroe Islands are small, and we don't have many doctors, and not many doctors within each field. So it would also be very dependent on the specific clinicians. So without pointing any fingers, there can be differences within specialties in how well they have performed the registration. So urological cancers are one that probably could have been a bit better, and brain cancers, that's a bit more complex perhaps. I think if it wasn't a classically malignant brain tumor, such as a meningioma, it wouldn't always be registered because it wasn't always known that should also have been registered. So that's maybe one of the reasons why brain cancers had a bit of lacking in reporting.
That's important in terms of comparability also, to well define and well describe and even document what you have on inclusion and exclusion criteria for your registration, because I see that you follow the NordCan guidelines, but I think, for example, also for bladder tumors, it's not really clear what everybody really puts in it, and that there is a heterogeneity or for comparison reasons that we have to be careful with that. I think that the same could be said from brain tumors, and also, like you say, the behavior of these range of tumors is also sometimes difficult to know. Should it be included or not, and certainly not for the physicians.
And that's one of the goals of the NORDCAN group.
Yeah.
Is to also what they have done over time is to try to harmonize how do we register.
Yeah.
So in the conference that we're having next week, there is for expert registrars, the coders, they have meetings where they talk about these things. How do you register urothelial tumors and so on, to try to harmonize it.
Yeah. Okay.
But otherwise, you're of course right. There are potential differences there.
Yeah. I have some questions also for you on your childhood, for example, and on your COVID article. I would like to go a bit further on the questions of Professor Muller, when he also asks, I completely agree with you when you say, no, we have followed pathology and we see the recoveries, we see the decreases, etc. So, and that is captured again afterwards. We did a check also, for example, in Belgium, and we saw with 2020 and 2021 that it differed maybe 1% or something afterwards. So that was okay. But did you see any influence? And I'm aware of the small numbers. You're right to mention that every time. But did you see anything on age specific or tumor specific? Because that would be interesting to know. That could have been different over time. Do you have any idea on that?
So there is, in the published article, we do not look at that, but there is a collaboration ongoing amongst Nordic countries where we have several aims looking at other things regarding cancer during the COVID era. And this is something that is included in those analyses. So I don't have the data yet, but it's something we're working on. But I'm a bit doubtful how much we'll be able to say from the Faroe Islands, but it will be very interesting to look at the other Nordic countries, and then we can say we were with on
some countries really saw a very steep decrease for 80 plus or even 75 plus. So it would be interesting to have a look at that, but you really don't see a decrease.
And I also think one of the interesting things with the Nordic comparison article I just showed was that Sweden had both the largest decrease and similar, also they didn't really catch up. While we all know that Sweden had very few restrictions. So in one way you could think it was the opposite, but it's probably because some of the older citizens were afraid to seek the doctor and thereby get their diagnosis.
Yeah. So and if you have a lot of deaths, do you think that it would influence also maybe that they cannot get a cancer anymore?
Their death of COVID or some other reason, and then they will not get their diagnosis. Yeah. That's also true.
The denominator, but that does not seem to be the case neither. So it could only clarify some dozens of cancers, for example, in Belgium. Is it possible that here a patient really gets a diagnosis outside of that, he really goes for the diagnosis even directly to Denmark, for example? Are these the cases that you fear to contribute to that underreporting?
It is a possibility that a doctor in the Faroe Islands would say this is a suspected cancer, and then they would go to Denmark to get the diagnosis, get an operation. Maybe they're finished with their treatment in Denmark. We wouldn't even see them in the oncological department in the Faroe Islands. That would be a possible missing case for us. Again, I can't know because I don't have the data. I don't feel like it's a lot. I don't feel like that's gonna put us up to the incidence in the other Nordic countries, but there might be some cases added. And this is one of the reasons why I really want to get data from Danish health registries. Because then we could say also, if this doesn't show anything, that we don't think that there are many of these.
And do you think that with your method that you have used to look at the COVID effect, do you think that you could use that method for the future? to have quick estimates or?
Yeah, it is definitely we could. It is a method which is not as specific as if you use the cancer registry data.
Did you match?
No, I haven't matched. I was thinking about that. I probably should have done that afterwards, but I haven't.
Yeah.
But it is something we could do. But if I look at, for example, the figure with the missing cases, where I find 389, I think it is, I actually start with 754.
Yeah.
So this almost doubled the cases had an cancer diagnosis somehow, but were not counted. Some of these were, of course, double registrations, and then not really a faulty registration. But so it isn't quite as good a metric. Perhaps rather than doing that, I think Norway has had a high ambition to complete their cancer reporting for the previous year. I think they did it in June this year, and they are planning to do it in March, so only 3 months after the year has ended. So that is something maybe one could strive again at, rather than using more of this, is actually getting the full cancer registration, but quickly.
Yeah. I have 2 questions left for you, for maybe some dreams to be pronounced. So the first is, you managed to work also with the kind of, let's say, machine learning or text recognition, I don't know how I have to call it, but which goes a bit the way for artificial intelligence. How would you like to see that in a small registry like you have, for example, in the Faroe Islands, versus a larger population? What do you think about it? What are your ideas about it? What you have used as techniques, and go further a bit in?
Yeah, so I have mainly, of course, thought about what can I do for the Faroe Islands, but it's an interesting thought to how could this contribute also to other countries, and perhaps, I don't know, countries with less complete registration outside of the Nordic countries. I don't think my method is directly translatable to other countries. It's very dependent on knowing the hospital system and exactly how is it done here. So it would, I'm not really sure I have a short answer, but it's something to think about. How could I contribute to other countries as well? It would be interesting.
But it's good that you use those techniques, and I think that some cancer registries could benefit of that technique to be implemented in their cancer registry, because they are all suffering a bit, I think, from shortage of budget or whatever, and I think that we should open up to more innovative techniques, and I think you managed to use a lot of it, and also I think your kindness to the oncologist, I think also the bond you have with the direct, with the clinical community is extremely important, and with the pathologist that is working there, and now also with the Danish Health Registry. And my last question for you, if I still may, if the time allows me that, I would give you a very large budget for here, and I would like to know what would you do first with that, and then of course your dream, but I would also like to know your dream team for that, to promote cancer registries, because I try to play a bit my role also for the European cancer registries, to promote the use and the quality of the cancer registries in order to contribute to cancer control. So what's your dream?
Oh, there are many things. I think one thing would be to actually do that manual check
you have a lot of money.
all of the variables, to add them that I know that are missing, and then do some more analysis.
What is missing?
The TNM stage and the treatment sometimes. If we could go manually through it, then we would have a complete registry. But if I were to look a little bit broader, I would focus on the NordCan collaboration, I think, and how that could be developed, because that's a way for me to bring something to a larger picture. I've thought about a little bit myself on, we show 1 and 5 year survival. Yeah. Why not do 1, 2, 3, 4, 5, 6, 7 year survival, and be able to show much more data? and it is perhaps a bit difficult to get an overview when there's so much data, but the Nordic cancer registries have such an abundance of great quality data. There's really a lot of potential for knowledge from those registries. So somehow to expand that to show even more what we can, I think that would be an exciting prospect.
Okay, and your dream team, don't forget.
My dream team, yeah, I really like working with my NordCan colleagues. I'm not really sure how to answer that, but some, yeah, and I'd love to have more researchers who are interested in the Faroese cancer data as well. I have some students, some are here, which are slowly beginning to work on some data. It would be lovely if they would like to continue also after the current projects. If we could be more who were interested in Faroese cancer data, we could do so much more.
Okay. They will pick up your enthusiasm, I'm sure. So thank you, Mr. Dean and Mr. Chair of our group. I have asked my questions. Thank you very much.
Okay, thank you. Then we are ready to let the examiner go out and make a votation. I think we should just stay here because I think they will be here in a few minutes. So let's see.
his Ph.D. dissertation on cancer epidemiology. We, the panel of examiners, conclude that Marnar Fríðheim Kristiansen, by the dissertation and the public defense, has documented the ability to carry out a research project by independent application of scientific theories and methods, and in that way has contributed to advancing research at a level meeting international standard. The panel of examiners recommends that Marnar Fríðheim Kristiansen is awarded with a Ph.D. degree.
Here we have the diploma and some flowers as well. So, thank you. Thank all that have been contributing to the work as well. Thank you. Now we have idag nu har vi några forskningar som är här på barnen som tittar på
And just a short thank you to all of you for attending. It was a great experience. Thank you all for being here. Great to see so many. Tack för det.